Professor Bala Venkatesh. Bala is someone that I've been very fortunate to know since my earliest research days, and he certainly is very well known in Australia and internationally as a leading critical care researcher, particularly in the area of steroids, where he's published the largest steroid trial in the context of critical care. We're very fortunate to have him speak to us on the topic of use of steroids in COVID-19 disease. He is the Director of Intensive Care at the Wesley Hospital. He also works at the Princess Alexandra Hospital and has affiliations at the University of Queensland and the University of New South Wales. And as Steve alluded to, he holds a professorial fellow position at the George Institute, and he's really facilitated a lot of the wonderful Indian sites coming on board for the ASCOT trial. But it's wonderful to have you on board, Bala, and we very much look forward to your presentation. Before you do, I just wanted to note for everyone who's joining us that Brisbane is about to experience a very large thunderstorm, and we hope that everything will remain okay in that context. So bear with us. Thank you.
Thanks, Jason. Thank you for the invitation. I'll get my slides up on the screen. Just 1 second. Can you see the slides?
Yes, thank you.
Okay. So Jason, once again, thank you for the invitation. It's a great honor to be here, and fantastic program. And thank you for your leadership in setting this up. And it'll be a very, very useful educational exercise. So as part of this presentation, what I want to do is to review the evolution of knowledge of using steroids in respiratory infections in general, then focus on viral pneumonias, what's the evidence base, and then focus specifically on coronavirus pneumonias, and look at the rationale for steroids in COVID, and then look at the 4 really large clinical trials which were reported in 2020 with the systematic review and meta-analysis which followed that, and look at some of the research questions for the future as far as steroids are concerned. Now, these are my disclosures, and the 2 things I just want to, in relation to this presentation, are that I was on the writing committee of the REMAP-CAP steroid trial, which was reported in JAMA, and I'm on the management committee of the COVID steroid 2 trial, which is currently ongoing. So the first question is, how did steroids come to be used in respiratory infections? And I guess the interest began way back in 1951 with the use of cortisone in upper respiratory infections with streptococcal sore throat. And it was a trial conducted in the US in the military barracks, and patients were assigned to either cortisone or placebo, and patients assigned to cortisone had a much more rapid resolution of symptoms. Over the next 30 years, then as more research happened, people found evidence of benefit in bronchiolitis, in obstructive lung disease like asthma and COPD, and some evidence of benefit in RSV infections, although not convincing, and similarly in aspiration pneumonia. Now, around this time, there was also a key discovery, which was the description of ARDS in 1967. And the reason this is important is that pneumonia is associated with ARDS. There is evidence of ARDS in COVID-19 patients, and there's evidence of steroids playing a beneficial role in ARDS. And therefore, we just need to keep this in mind as we go through the rest of the talk. And then in 1990, a key paper emerged, which really looked at patients with severe pneumonia, particularly of an interstitial pneumonitis, as you would see with PCP in patients with HIV infections. And they demonstrated in this randomized controlled trial that patients receiving corticosteroids had better survival and better respiratory function. So the case for steroids in severe pneumonia really was built up on the background of an underlying severe inflammatory response, and steroids are anti-inflammatory, the presence of a lung injury, particularly there being an interstitial component, and often pneumonia can progress to ARDS. So this set the scene for a clinical trial of hydrocortisone in patients with community-acquired pneumonia, led by Confalonieri, and they looked at 46 patients who were randomized to either hydrocortisone or placebo. And interestingly, as you can see in this graph there, in the patients with receiving hydrocortisone, shown by the horizontal white line, there was 100% survival. In the placebo arm, the survival was 75%. Well, the numbers were too good to believe to be true, and therefore patients said, well, the researcher said, we've got to repeat this in a larger trial. A number of other trials happened, and clearly the evidence for steroids was not so convincing. Nevertheless, the meta-analysis in the Cochrane meta-analysis in 2017, you can see there the overall, the point estimate is in favor of steroids with a risk ratio of 0.8, but the confidence limits exceed 1, showing that it is not statistically significant, but certainly suggestive of benefit with corticosteroids. In our own trial, the adrenal trial, where we looked at corticosteroids and septic shock, in the subgroup of patients with pulmonary sepsis, again, there was no evidence of treatment effect with hydrocortisone on day 90 mortality, which was our primary outcome. So overall, there's probably evidence of some benefit with steroids in severe pneumonia, but there's no convincing data in terms of an RCT. So when it comes to viral pneumonias, the story is slightly different. The evidence base is limited because there aren't many studies, and the ones that exist are largely observational or retrospective, and there are very few RCTs. So this is a large meta-analysis looking at steroids in influenza pneumonia. And this is data from about 10 observational studies looking at 6,500 patients. And the message is very clear. In patients who received steroids, the mortality was much higher. They did worse. And in the same paper, you can look at subgroups of influenza there. You can look at the H1N1 pneumonia. And again, the message is very similar. Patients receiving steroids had a worse mortality. If you then focus specifically on the coronavirus pneumonias, there were 2 randomized controlled trials. The first one was in the SARS epidemic back in 2003, where they looked at high-dose pulse versus non-pulse corticosteroids, and there really was not any difference between the 2 groups, and overall they concluded there probably wasn't much evidence of benefit with corticosteroids. And then the second one was more recent in the Middle Eastern respiratory syndrome. This was comparing corticosteroids versus placebo. This was led by Yassine Arabi, and basically, once again, they found no evidence of benefit with corticosteroids on the primary outcome, but more interestingly, they reported a delayed clearance of the virus in patients assigned to corticosteroids. So that brings us now to COVID, which is another coronavirus pneumonia. So the question really is, why should steroids work in COVID-19? I guess one of the things, as Professor Tong mentioned in the earlier talk, this pandemic was a global pandemic, which led to a massive international research response, with the result that we gathered a lot of information in a short period of time. So we understood the pathogenesis of COVID much better, and we understand now there's a hyperinflammatory state, they have a cytokine storm, and nearly 1/3 of the patients have circulatory shock, and both on autopsy studies and on CT scans, there's an evidence of ARDS type of picture. So for these reasons, people believed that that steroids should have a beneficial role. And there's a nice sort of an editorial by, again, Yassine Arabi on why steroids might reduce mortality in severe COVID-19. This was published in Intensive Care Medicine recently. So interestingly, in February of last year, when the pandemic was just gathering momentum, this paper by Jesus Villar looking at dexamethasone for ARDS showed there was evidence of improved survival in patients assigned to corticosteroids. You can see the Kaplan-Meier curves there, and the results were statistically significant. He used high-dose dexamethasone. So again, this provided further support and justification for considering steroids in COVID-19, which has an ARDS component. So in 2020, when the original observational data from China suggested that steroids might be of benefit, 4 RCTs then followed from there. They were conducted in a rapid time frame and they were reported in 2020. The first was the recovery trial, which Stephen alluded to. That was reported in the New England Journal of Medicine, looking at dexamethasone. The second was the REMAP-CAP trial in ICU patients in COVID-19, which used hydrocortisone. The third was the French trial, the Cape COVID trial, which looked at hydrocortisone in critically ill patients in COVID-19. And the last one was the Codex trial from Brazil, which looked at dexamethasone in patients with COVID-19. So the 4 trials, 2 looking at dexamethasone and 2 looking at hydrocortisone. These were the key results. In the recovery trial, which enrolled nearly 6,500 patients, randomized 1:2 ratio dexamethasone to usual care, there was clear evidence of benefit in patients receiving dexamethasone in terms of day 28 mortality. And it was particularly evident in the patients in the group receiving invasive mechanical ventilation at randomization or receiving just oxygen support at randomization. Interestingly, in the group who were not receiving any oxygen at randomization, there was evidence of harm, or I probably would say that usual care was better, although that was not statistically significant. Now, in the REMAP-CAP trial, the primary outcome was organ support-free days at day 21, and there were 3 groups: a fixed dose hydrocortisone group, which is 200 milligrams of hydrocortisone per day for 7 days, or a shock-dependent hydrocortisone group. This is COVID-19 with circulatory shock and hydrocortisone at 200 milligrams per day given for the duration of shock up to a maximum of 28 days, or the third group was no hydrocortisone. And on Bayesian analysis, the conclusion was both groups of hydrocortisone there was a greater probability that they were better in terms of primary outcome as compared to the no hydrocortisone group, although they did not reach the statistical threshold for significance. The Cape COVID trial, which is the French study, that's the only blinded RCT, and that looked at 149 patients, either randomized to hydrocortisone or placebo. And the primary outcome was treatment failure on day 21. And it was 42% in the hydrocortisone group versus 50% in the placebo group. Again, the p-value was not statistically significant. And the last one was the Codex trial, which looked at 299 patients. And the primary outcome was days alive and free of mechanical ventilation. And patients assigned to dexamethasone had greater number of ventilator-free days, almost 2.5 days more than standard care, and the results were statistically significant. So the results of these 4 trials and a number of other smaller trials which had to be stopped following the recovery publication were all pulled together in a meta-analysis, which was also reported in the JAMA. And you can see the forest plot there. And overall, the message is it's in favor of steroids. When it came to mortality, it was beneficial. Steroids were beneficial as compared to no steroids. And particularly evident in the subgroup of patients receiving mechanical ventilation, as you can see there, or receiving oxygen treatment, or who presented with greater than 7 days of symptoms, which is right at the bottom here. So in all these 3 subgroups, there was clear evidence of benefit with corticosteroids. Now, Stephen talked about the recovery trial. I think it's worth talking in more detail because that was the largest trial. I just want to go back to the previous slide there. It is, and you can see the size of recovery here, and that dwarfs all other trials when it came to the sample size, and it contributed to nearly 57% of the weightage when it came to the meta-analysis as compared to all the other trials. So without recovery, obviously the evidence for corticosteroids will not be so strong, and that needs to be kept in mind. So when we look at the recovery in more detail, there were some fantastic lessons to be learned from recovery, and Stephen alluded to how the entire UK came together, the collaboration between the NHS and the political establishment, the expedited ethics review, and from conception to the first enrollment was about 1 week, and the national buy-in, and I think it's a tremendous achievement. There were some limitations. This was an unblinded study. Now, 11,000 patients were eligible for the study inclusion. Of those, 2,000 were excluded because dexamethasone was not available. Another 3,000 were excluded because they were randomized to another drug. And so the remaining 6,000 were randomized into the steroid domain. Importantly, the decision on post-randomization treatments were such as mechanical ventilation and renal replacement were left to the treating clinician. And of course, I guess it's a pragmatic trial, and there's probably nothing else much you can do about this, but this is an important consideration to keep in mind. They did not report data on circulatory shock. And finally, and I think this is a very key issue, which is nearly 2/3 of patients who died who were not on mechanical ventilation at randomization did not receive mechanical ventilatory support. And I'll show this in more detail in the next slide. So this is the recovery trial, the table 2 from the NEJM paper, showing you the primary and secondary outcomes. And you can see here, this is the group of patients who are not on mechanical ventilation at randomization. So in this cohort, 1,214 patients died, 387 in dexamethasone and 827 in usual care. And then you look at the number of patients who received mechanical ventilation in this cohort. That's 387, 102 in the dexamethasone, and 285 in usual care. So nearly 2/3 of patients who died without receiving mechanical ventilation. And it'll be useful to explore this in more detail, but this was not discussed in the paper. Now, although these 4 trials have definitely been very clear about the role of steroids, there are a few unanswered questions which arise from these. These were pragmatic trials, and so the question really is, should steroids be commenced based on the clinical status or biomarkers? And these weren't measured in the trials and clearly couldn't be done in the context of a pandemic. What is the optimal dose of corticosteroids? The Jesus-Villard trial, the ARDS trial, looked at 20 milligrams of dexamethasone, whilst the recovery trial looked at 8 milligrams of dexamethasone. So the question is, what's the optimal dose? Are there differences between the subphenotypes of ARDS? Is there inflammatory rebound if you stop steroids? Should they be tapered rather than stopped after a fixed duration? The adverse effects weren't reported in great detail because obviously the trial was done in the context of a pandemic. And really the question about did it impact on viral clearance is something which was not evaluated in detail in any of these trials. So we are looking at one of these questions, and this is a collaboration between the Danish group and the George Institute for Global Health. This is the COVID steroid 2 trial, looking at higher versus lower doses of dexamethasone in patients with COVID-19, comparing 6 versus 12 milligrams of dexamethasone for 10 days, with a primary outcome being days alive and free of life support. And the target sample is 1,000, and we've enrolled close to 600 patients to date. So to conclude, the data from a large RCT and a few other smaller trials suggest evidence of benefit for corticosteroids in patients with COVID-19, particularly those requiring supplemental oxygen or ventilatory support. Although dexamethasone was the one tested in a large population, the results suggest it's a class effect. It's not dexamethasone specific, but it's more corticosteroids group effect. The recommended duration based on the available evidence is somewhere between 7 to 10 days. There's no evidence of harm or significant harm that we can see, and further clinical trials are underway to understand the role of steroids in more detail. But thank you for your attention. I'm happy to take questions.
Thanks very much, Bala. That was a wonderful summary of all of the data and the rationale for why steroids seem to have a very strong benefit in COVID-19 and what the remaining research questions are. Congratulations on the enrolment so far and your trial too. There is one question here from Nathan Bartlett, and he would like to know whether or not there's any data on clinical outcomes for COPD patients that are on corticosteroids prior to developing COVID-19, as opposed to COPD patients not on corticosteroids.
Look, it's a great question. I think there's some trials have reported in the baseline group, the baseline comorbidities. They've looked at COPD in some of the groups, and there are, and in the trials that we can see where there's been baseline equivalence, even in those groups, there's been some benefit with corticosteroids. So at the present time, the recommendation would be that that steroids should be administered to these patients.
Thanks very much, Bala. In the interest of time, we'll move on to the next speaker, but there's 3 more questions for you in the Q&A tab that I'd be grateful if you could keep an eye on and maybe pen a response to.
Sure.
Thanks very much, Bala. It was a wonderful presentation.